Welcome everybody. My name is Bill Soares. I'm an assistant professor of emergency medicine at Baystate Medical Center, and I get to talk about how you can save a life every shift, harm reduction for the busy emergency provider. I have no conflicts of interest to report on this. So, keeping in mind that we are all extremely busy as emergency providers, our goal today is to come up with a practical, efficient, evidence-based harm reduction algorithm for our emergency department patients with substance use disorder. Now, it's important to note that critical to the discussion today is the understanding that substance use disorder is a disease. Now, while many of us may say this, it really is hard not to think of substance use disorder as different than other diseases or as a choice. However, it's this conflict that continues to undercut how we treat physicians and how we treat patients as physicians. So I wanted to dive a bit deep because this is really going to set the foundation for the rest of the lecture. By definition, a disease is the influence of factors such as genetic, developmental, infections, poisons, environmental that cause a disorder or incorrect functioning of an organ, structure, or system of the body. Take something that we all agree is a disease, cancer. There typically can be genetic or developmental components. There can be the influence of toxins or poisons, even the influence of environmental factors can all lead to this disordered or incorrect functioning of a system. We all agree on this. Let's take the exact same definition for substance use disorder. Genetics. We know that there is a strong genetic component to addiction that's demonstrated independently of environment. Poisons or toxins. With any addictive disorder, there are physical changes in the body that occur because of use of a particular drug, poison, or toxin. Now remember that especially for opioid use disorder, many of the times it was we, the healthcare provider, that first introduced that toxic substance to that patient. Additionally, environmental factors, how we grow up, the strong association of drug use with history of abuse, childhood abuse, sexual abuse, co-occurring substance use in the household, peer groups, all of these go on to influence substance use disorder. And they all go on to lead to an incorrectly functioning organ. And here's where I want to spend a little bit of time. Remember that opioids, like any other substance that is addictive, it engages the primal reward system of the brain, affecting neurotransmitters like dopamine. It's the continued exposure to drugs like heroin that causes the body first to downregulate and then to rapidly damage these neurotransmitter productions. So what you see on the screen is an image, fMRI image of a patient who uses methamphetamines. The black areas are areas where there's no metabolism, there's no uptake. Those are damaged and dying and dead areas that is specifically related to the reward system of the brain, secondary to damage from methamphetamine use. That is the disease of substance use disorder. At best, there is downregulation. At worst, there is permanent damage of these neurotransmitters, and that is the definition of a disease. So why am I stressing this so much that it's a disease? Well, here's the thing. We know this. We think this from a pathophysiologic basis. We can say this, that addiction is a disease. But in our minds, deep down, when you look at these two pictures, do you see the same disease? Is it that in our minds, things like bias, stereotypes, affect and influence how we respond to these two patients? And so it's really hard because that is normal for us. That is normal in this disease process that is substance use disorder. So it is really helpful to continually remind that in fact, substance use disorder is a disease. And when we see it in the emergency department, we are not seeing that this is this person. What we're seeing is this is the reflection of the disease itself. And if we can treat that disease, then all of a sudden the actual real person will emerge. So there are important foundational points if you're going to engage in harm reduction that you have to understand when we talk about substance use disorder being a disease. First, if it's a disease, then it's not someone's choice. If they have substance use disorder, they can't just choose not to have it. Second, as healthcare providers, if something is a disease, it is worthy of evidence-based treatment. That means that it's not up to the person to prove to me that they should be treated, but in fact, just in the fact that they have the disease, they earn treatment. Additionally, it's important to note that as a disease, and especially as a chronic disease, non-compliance is normal. In substance use disorder, it's not failure to relapse. That is part of treatment, and we need to address it as such. And then finally, similar to folks with cancer and other very serious diseases, success may be defined differently, and it may be different than what you expect. The idea of what the patient considers success and successful treatment. So you may be thinking, yeah, I believe it's a disease, but I'm an emergency physician. This is not my place. Why is it my job to treat this disease? 2 reasons for that. First, yes, substance use disorder is a chronic disease. However, research clearly has demonstrated that by the time they reach us, it is a life-threatening emergency. On the screen is data from Massachusetts emergency departments of patients who have opioid use disorder who survived an opioid overdose. And they were followed for 1 year, looking at their survival after that index overdose. Now, if you look at the solid line going up, that's their 1-year mortality of folks who had no treatment after that visit. And that 1-year mortality topped out at 5%. Now, these are otherwise young, healthy individuals. No other disease process in this age group of individuals comes close to a 5% mortality. So yes, substance use disorder is a chronic disease, but just like other chronic diseases, it can have emergent conditions, and when it comes to us, it converts over to an emergency. The second point of why you should care about this is treatment works. Same graph, same population. Look at the lower lines. When patients engage in treatment after an ED overdose, their 1-year mortality drops to less than half. Specifically listed, buprenorphine drops mortality from 5% to 1.8%. That is a huge reduction. So not only is it an emergency, but the things that you can do immediately in that emergency department can actually save a life. So let's talk about this idea of harm reduction now that we've kind of created this foundation of substance use disorder as a disease and why it's important. Harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction at its base is built on the belief and the respect for the rights of people who use drugs. So when I think about harm reduction, I think about it as it's a spectrum, right? And people can fall along that spectrum, and it's normal to fall along that spectrum of what they expect from their disease. They can fall to one side where they are ready to accept treatment and fully engage, all the way to the other side where they refuse treatment and they don't want to stop, and right now they are not ready. The idea of harm reduction is at the basic understanding that our job as healthcare providers is to support the patient wherever they land on that spectrum, rather than demanding they have to go to a certain point in that spectrum before we'll treat them. Now, for our thinking, for the patients with substance use disorder that we see in the emergency department, we can broadly define harm reduction spectrum through some basic terms, and we take these terms from trans-theoretical model of change. You can imagine that people will in general fall into 3 buckets that we see who have opioid use disorder or a post-overdose. First, they can be pre-contemplative, which really means they're not really thinking about treatment yet. They're not ready for treatment. Second, they can be contemplative, where they've thought about it, but they haven't taken any further steps. There's still a lot of question and hesitation. Finally, they can be in the preparation phase, where they have come to a point where they are actively ready to engage and they are ready to move forward with treatment. Now, you have to understand this is important because this is a big shift from what many of us do in our current practice. Now, luckily, with evidence-based medicine and laws, many of us know about Suboxone. Many of us will offer Suboxone, which is great. It is such an improvement from before. But realize that when I see folks who are engaging patients with substance use disorder, more often than not, with providers, it kind of goes like this. Do you want treatment? No? All right, we'll get you discharged. Right? That is not harm reduction. That is trying to fit them to the mold of, you're not ready, I don't have much to do for you. And it means that the experience of folks who are trying to prescribe Suboxone, they come on and tell me, yeah, I'm ready to prescribe, but nobody wants it. I do it very rarely because no one's ready. I would like to offer a different model. Now, this comes from an algorithm that uses something called the 5 A's, which has been used in tobacco cessation before. The 5 A's: ask, advise, assess, assist, and arrange. So the first thing you have to ask, you have to know, does this patient actually have substance use disorder or opioid use disorder? For some people this is obvious, but for others, our chronic pain patients and others, it may be a little bit more hidden. So it helps to ask, are there physical symptoms? Is there withdrawal? And is this negatively impacting your life? Are you buying opioids off the street? Are you searching more for them? Are you increasing your dose? Is that all you think about? Is it affecting your life? Those are some of the hidden signs that this actually could be opioid use disorder or transitioning to that. The next thing you want to do is you want to advise. You want to lay it on the table. You are a medical professional. You know the risks. You have someone that comes in with an opioid overdose. You tell them, look, I'm worried. Your chance of dying is high. Based on what we know, for every 20 people we see after an overdose, 1 is going to die. Or for you, in the next year, you have a 5% risk of dying. The next part's a little bit different because it's something we don't do as often, but you want to actually assess where they are. And that's just asking them, right? You're my patient. My job, what I care about is keeping you healthy, keeping you safe. Are you interested? Have you thought about treatment? Have you thought about trying to quit? Have you thought about medication? Right. Now, rather than what we've done before, as simply say yes or no, well, I'm going to give it to you or not, what I would advocate for is actually just trying to group people into a few different answers. There's going to be the yeses. There's going to be the folks that survive their opioid overdose and come to the moment of, I really need to stop. I am really ready to stop. And that is great. That is amazing, and that should be taken advantage of, right? They're in the preparation phase. So if I'm thinking about that, now realizing that I'm a busy emergency provider, I cannot spend 45 minutes likely with a patient. It's really hard. So if I'm going to get the most for the time that I spend, that person that's in the preparation phase, they're ready. I'm going to prioritize making sure they get medication and making sure they have a follow-up, taking that energy and transitioning it to where they are going to follow up and continue. If I'm strapped for time, I may not talk about safe ways to inject. It's important to, but at the same time, they're ready to stop. They're convinced, I'm going to stop right now. Engaging them in, well, yeah, but you might use tomorrow, so let me show you how to inject, is good and it's important, but it also might put them off because you're not listening to where they are. So it's not to say you shouldn't talk about it, but we all know with our time frame, you want to prioritize, you are ready to stop, I'm ready to support you, let's make that happen. Let's take the other end, because honestly, the yeses, the folks that are in the preparation phase are pretty minimal, right? That's probably only about 10 to 20% of the people that we see. What about the people that say no? And we see a lot of these folks. Again, they have survived their overdose or they're here and they say, no, I'm fine, I really don't want anything. The typical thing to do has been to say, well, you don't want anything, I can't help you, goodbye. And I would ask you to reframe that, to say, okay, if I'm doing harm reduction, that's okay that right now you don't want treatment because I know that could change later. So my job is to try to keep you alive and healthy until maybe in the future when you actually want treatment. And there are a few ways that we will talk about more in detail later that you can do. First, they can get Narcan. They can get take-home Narcan, which we know is life-saving. Second, you can talk about if they are going to continue to use and if they are going to continue to inject, how they can stay safe and not overdose and not get an infection. What does that do? It gives them information, but even more so, it brings it down where you are to their level. You are talking to them and you are respecting them as a person and you are building trust. And I will tell you, the folks that I have done this with, and we have done this with a lot of our folks, more important than the exact mechanism of what you say is just that idea that you're saying, you know what? You are a person and a capable decision maker. This is your decision. Let me help you and support that and make sure you stay safe. And that is really powerful in itself. Finally, we get to about 30 or 40% that say, I don't know. Maybe I'll try treatment, but I don't know if I'm quite ready. Now, for me, this is contemplative. If I take that person and say, okay, I got you Suboxone and I got you an appointment in 5 days and I really worked hard for this appointment and go to this appointment, they might not because they're not totally convinced that this is what they want. At the same time, if I say, well, you're not 100% for me, so I'm not going to give you medication, means they have zero chance, right? We have ruled out for this visit that they are going to get treatment. So what would I recommend? My talk with them is really to try to empower them to try the medication. to try to have an experience with a treatment that will stabilize their life. And that's important. I'm not talking about, well, which clinic do you like and how you're going to get there. I'm talking about for the next 5 to 7 days, let's try a medication. Let's see what it's like to wake up and not feel like you need to run out and buy drugs and not feel like you need to roll the dice and possibly die when you inject. Let's see what stability looks like. Let's see what that feeling is, because that may in itself convince you that you want to continue. And these are actually the folks where I think about recovery coaches. If I'm going to activate and I'm going to spend time, I'm not going to spend time necessarily looking for a specific follow-up clinic, but I'm going to spend time looking for a person that can guide them through that. So again, we have our 5 A's, and the biggest change is the idea of whatever they say, we're going to have a plan of specific things that we can do to focus their treatment. For the next few minutes, I just want to go through some of the specifics of medication, buprenorphine, Narcan, harm reduction, and safe usage, and resources. Most of us are familiar with buprenorphine. I'm not going to spend a lot of time. For those who maybe are a little less familiar, it's one of only 3 medications approved for the treatment of opioid use disorder. It's a partial agonist, which means when it latches onto a receptor, it only activates at 50%. That's independent, so even if all receptors are full, it's still only going to activate 50%. It also has a very high affinity and will displace other opioids. This leads to what we hopefully infrequently see, where people will experience withdrawal symptoms if we give them buprenorphine too soon after they have used another opioid like heroin, what we call precipitated withdrawal. Because the buprenorphine in itself has a higher affinity than heroin, than methadone, than many other opioids. When we talk about Suboxone, it's still the buprenorphine. It's still a partial agonist. It still displaces. It still can cause that premature withdrawal. But it also has this added naloxone component, which supposedly only works if it's injected. So really, if someone is taking Suboxone or buprenorphine regularly, they're not really going to notice a difference. And then finally, as many of you know, it requires a DEA-X waiver to prescribe. Now let's talk about some more important things to remember that are more clinically focused. First, it has a very strong evidence-based mortality benefit, with a number needed to treat of about 30. Now I would challenge many of you to find a medication that you prescribe a discharged patient that even comes close to a number needed to treat to prevent death of 30. Those are numbers that we talk about for ARDS type ventilation, right? 1 in 12 to 1 in 15, right? That is not something in a prescription we are giving to someone who is walking out the emergency department. So that's the first thing. If you really want to save lives, above any other medication that you have likely prescribed, this medication has the highest likelihood of or chance of saving a life. Second, in patients who are tolerant and patients with opioid use disorder, this is safe. They are not going to overdose on buprenorphine alone. It is incredibly difficult because it only, even if it's 100% of receptors, only activates 50%. The third important point that I hear a lot, this is not typically diverted for recreation. People don't buy buprenorphine off the street because it is their drug of choice. It is much easier, it is much cheaper to buy heroin, and so people will go to other opioids. That's not to say that it's not diverted, but you have to understand why it's diverted. Typically, buprenorphine is diverted because other people want a day where they don't have to use. So I think of it a little less like diversion and more like rationing insulin. Right? And the issue is, the reason we have an issue with diversion of buprenorphine is because not enough people are prescribing it. And so people can't get it from their doctor, they can't get into clinic, and so they are getting it by any means necessary to try to stay clean, even if it's just for a day. And then finally, to note, well, what if they go out and use? Remember the high affinity. If buprenorphine is on and in their system, it is harder for heroin to get on, and it's just a little bit harder for them to overdose. It is not impossible, and they can still overdose, but it is a little bit harder, and so it's a little bit safer. For me, and this may be different than your practice, I give a 7-day prescription. They have a clinic visit the next day, I give a 7-day prescription. Why? Because I want to give people buffers. Because yes, they have a clinic appointment the next day, but maybe I feel sick and I can't go, and because it's COVID. Maybe I didn't realize that my insurance lapsed and not activated, and now the clinic's not seeing me. If I specifically give 1 day or 2 days just to get them up to that clinic appointment, the likelihood that they will have a gap and go back to using is higher. You would not do this for your hypertensive. You would not say, you have an appointment in 6 days, I am going to give you exactly 5.5 days of antihypertensives. Why do that for your folks who you're trying to stabilize? Most of my patients will self-titrate at home. Again, this is pretty safe. And honestly, most people will under-titrate a bit. So I tell them you need to take a little bit more. For me, there are very few contraindications. If you have opioid use disorder and you're interested in treatment and you want to try Suboxone, I am okay with that. But there are some contraindications, methadone especially. You have to be very careful with folks on or transitioning off of methadone. Liver failure, I don't want LFTs, but if they have overt liver failure, that concerns me. And obviously if they're altered. And then for me, an important point that I think gets into those folks who aren't quite sure about treatment, I'm okay if they don't have dedicated, established follow-up at that moment. Because again, we're thinking harm reduction. I'm not thinking this prescription is your cure, and if you don't have follow-up, I need to refuse this medication. I'm thinking we're going to work hard to get you follow-up, but I also want time where you're not using. Because it could have been on that day 3 that was the dose of heroin that you were going to buy that was going to kill you, that was going to give you the endocarditis. And by giving you those days, by letting you experience what it's like to not need to seek out illicit drugs, that is that idea of harm reduction. Narcan. We are not going to talk about the physiology of Narcan because we all know it. But there are some things to know and some updates. First, this past year, Mass Health stated that they would reimburse take-home Narcan directly given from the emergency department at near full cost, which can make this very sustainable for emergency departments to give Narcan physically to people. Realize that additionally, what has changed, our supply of heroin, especially in Massachusetts, has changed, and it's now requiring 2 or more intranasal Narcans to reverse overdoses. 1 is not enough anymore. Obviously, you're still able to purchase at pharmacies without a prescription, but the cost is approximately $115 to $130 and often unattainable for folks. So seeking out and knowing where your syringe access or needle exchange, where you can get free Narcan, where patients, where family members can get free Narcan is really important. And then obviously something we sometimes forget, but Narcan is useless if it's sitting in the pocket of someone who's overdosed. So telling them this is what you do. If you have a friend and you can alternate using, use that friend. Take the Narcan out, put it next to you. If you don't have a friend, you need to be somewhere where you can be found. If I have someone and I see them on the ground and I see the Narcan is out next to them, I am much more likely to know what is going on and to quickly give them that Narcan versus otherwise. So teach them those basic things, and that's going to help prevent that next overdose. Safe usage. Now we're going to talk, and I specifically focus this on the folks who say, you know what, I don't want treatment now. I'm not ready. Because typically what we've said to those folks is nothing. Goodbye, we have nothing else to do. And I want to challenge that and say, no, we do have something. Now where we are, we have actual kits that have supplies, especially for folks that inject, to try to prevent infection. Because we know abscesses, cellulitis, endocarditis, cranial abscesses are all on the rise, and they're all devastating. Not to mention the epidemics of hepatitis C and HIV that are reoccurring because of this. But say you don't, say you're working tomorrow. You can still talk about this, and there are some simple things you can say, right? Realize that folks that inject drugs, they haven't often been trained, right? They don't know procedure. They are not medical professionals. So even basics. Bacteria lives on us, on our hands and our skin. Wash your hands. Prep your skin with an alcohol pad. I will hand them, if I don't have a kit, alcohol prep pads. They cost less than 2 cents a pad, right? Sterile water. Most people think the bottled water that they get is sterile and will use that. Again, we have an abundance of this. A small bottle, a 100 or 250 cc bottle of sterile water may be preventing that next endocarditis. And then finally, for someone who's like, I'm not ready for treatment, I want to try to get you to a syringe access program, to a needle exchange. Because I know that's a place that is not going to judge you based on that. They're going to say, you're not ready for treatment, that's okay. Let's keep you alive and healthy. And that's where I want them to be. Final thing, referrals and resources. So one of the big things, and sometimes we do too good a job, right? We'll hand them the sheet with 100 resources. We'll say, call all these numbers, you're going to find something. And I would argue that really you want quality over quantity, right? No one it doesn't work. We know that it doesn't work well, especially if they're unfamiliar with those resources. So pick out a couple clinics, right? And this takes a little bit of legwork on your department's part. Talk to a few clinics. Who are going to be the ones who are going to be responsive? Use those, right? Be the ones that they are going to be the ones that talk to you and are reliable. I guarantee in your community somewhere there is a recovery coach program. Just connect and see what it takes to refer someone to there and use them. Additionally, there is going to be a syringe access or harm reduction program. Find their number and use them, right? That's about it. 4 or 5 resources, giving them to the way. It's not everything and it doesn't cover everything, but you know those have been vetted and those are reliable. And that's going to help that patient focus that I need to call this person. This is the number they gave me, rather than they gave me 50 numbers and said, good luck to you. Then finally realize that the co-occurring social issues and social barriers are real. It does me no good to give someone a prescription for Suboxone if their Mass Health has run out, because most people can't afford the copay and most people can't get into a private clinic if they don't have insurance. You don't have to solve that in the emergency department, but at least knowing, hey, I saw your Mass Health isn't up. Here's the number to our financial services. Here are the number of people that can fix it for you so we can get you into treatment. So to review, 5 A's. You gotta ask, you gotta see if they have substance use disorder. Most of the time it's obvious, sometimes it's not. Advising them. You're the medical professionals, you know the data, tell them the data. Let them know the real risk. And then you have to assess. You have to figure out, well, where are you on that spectrum? If you are in preparation and ready for treatment, then we focus on treatment. I'm gonna get you your prescription, we're gonna get you into a clinic, and I may focus a little bit less on saying, well, let's talk about when you use next, because it might not be received as well, and honestly, it's really busy and I can't fit everything in. If they say, nope, I'm not ready, I just wanna go, I'm gonna try to get some Narcan in their hand, and I'm gonna try to talk about, okay, you're not ready, that is totally fine, but I wanna make sure that you stay healthy. Here are some basic tips. Wash your hands, prep the site. Here is the number for a syringe access program. They can get you supplies. They can help you to stay healthy while you're using. That is 5 minutes, that is less than 5 minutes. And that's more than we normally do. And then if they don't know, honestly, I'm trying to get them on medication. I'm trying to get them a good experience just to show them. This is what it's like when you don't have to wake up and immediately try to search for drugs so you don't feel bad. And that may be enough for many people that they will then want to go into treatment later. Some last notes, what's headed up in the future? Sublocade is the depot Suboxone. It's a liquid that goes into the body and forms a more solid gel and lasts for a month. There are trials of folks using it in the emergency department. Interestingly, folks need to be on a stable 7-day course of Suboxone before they start Sublocade, another reason for giving 7 days. But that may be coming, and that is a very interesting and promising method of treatment. Overdose prevention technology is there now and is continuing to form. One of those is on the screen. It's called Canary. It's an app that can be downloaded. Someone that has a smartphone, and a lot of people defend on their phones. Someone who uses can plug in trusted contacts. When they activate Canary, it sets off a timer. If they don't purposely move the phone about once a minute, it will start to alarm as if they're having an overdose. It is very friendly and works decently well, I think. Because of COVID, there's been an increase in telehealth, which offers opportunity, especially for folks who might have limited transportation. And then finally, if we come to a point in this country where we actually want to save the lives of people who use substances, there are efforts that continue to try to have safe consumption sites where people don't have to fear that they're going to die. If you have questions, concerns, want to know more, want any of this information, want any of the resources we have, please shoot me an email, contact me in any way, and I'm happy to share all we have. Here are just some of the references. I appreciate your time. Go save a life. 31.
Can I ask you a couple questions?
Oh, yeah, totally.
So, are you doing any labs routinely before prescribing Suboxone? Because you did mention like LFTs.
No.
And with regard to the contraindication in coexisting methadone use, are you like confirming that with a negative UDS,
no,
or just based off talking to the patient?
Talking to the patient.
Okay.
Yeah, so methadone's hard. It is so, the metabolism is so variable, especially when you get over 40 or 50. If you're under 40, then I feel confident in a certain number of days that I can probably give it to you. Once you get to like, I'm on 150 and I've been off for 6 days, I've seen those people get into awful precipitated withdrawal. I'll usually push, I mean, if they really want it, I'll push for inpatient where they can treat them. I mean, inpatient, addiction, not usually hospital. It's tough. I've been burned a bunch of times with it.
And what about in patients that have received Narcan? So if they've gotten
Yeah.
Narcan and that precipitated their withdrawal,
Stupid annals. Did you purposefully give them Narcan to precipitate withdrawal so you could start them earlier? You saw that? There was a case report?
No, I did see that case report, but I'm thinking more about they've gotten Narcan and now they're here and they're withdrawing.
So say you were there and, literally like, oh, they're dying and like, the intern comes in and is like, bam, I'm going to save them, 0.4 Narcan. He wakes up vomiting. Sure, throw it in, right? The problem is I think we get them from the field and it's already been about 30, 40 minutes. So you just have to be careful because the half-life is so short, right? If it's anywhere getting close to an hour, I'm kind of like, this is going to wear off. And it's not that I'm afraid that I'm going to hurt them, but I'm afraid I'm going to kind of prolong their withdrawal because they're already to the point where those receptors are loading back up with whatever it is. So you can try, and especially if it's close to and they have severe symptoms. The other hard part practically is I don't think we have loaded in the Pyxis, the IV Suboxone, which is fine to give. It just may be a practical process of getting it down in a timely fashion. But if they can take it, you could try. And then they can continue on it. The other thing you talked about with the methadone, you can do microdosing 2 at a time and kind of see and watch and go through it with them.